Okay, what are the different DNA viruses you come across? First, we start with herpes virus. First, divide the herpes virus into simple subfamilies. You have subfamilies called as alpha, beta, and gamma. The subfamily alpha is referred to as neurocytolytic or cytopathic, having specific attachment towards the neurons. While the subfamily beta has affinity towards the lymphoproliferative activity, they'll try to attack the lymphocytes. And you have subfamily gamma that has no specific activity but can include HHV8 virus and HHV4 virus. What are the different names of each of them? HHV1 is human simplex virus or herpes simplex virus 1. HHV2 is, that is, human herpes virus 2, that is also herpes simplex virus 2. Look at herpes human virus 3, that is varicella zoster virus. In case of HHV4, you have Epstein-Barr virus. In case of HHV5, we have cytomegalovirus. HHV6 is human B-cell lymphotrophic virus. HHV7 is RK virus. HHV8, that is human herpes virus 8, is Kaposi sarcoma virus, which causes malignancies in the blood vessels, especially in people who are suffering from AIDS. Now, what are the different things that I want you to know about each of the viruses? If it is HHV1, because it has cytolytic activity in the neurons, I want you to remember they have latency also in the neurons. 1, 2, and 3, all of them can have latency in the neurons itself. While HHV4, that is Epstein-Barr virus, will have latency in the lymphoid tissue, while they'll be actively proliferating in the lymphocytes as such, which are B lymphocytes. If it is HHV5, because they are cytomegaloviruses, their effect is to cause cytomegaly. They cause enlargement of the host cell in which the virus is affecting. And where do they have latency? They all have latency. All HHV viruses will have latency in the secretory glands. Rarely they can have presence in the kidneys also. Now this should actually ring an alarm in your mind. That is why CMV can be a very important virus that spreads because of solid organ transplantation after immunosuppression. They are also present in other lymphoid glands. Then we have HHV6, which is called as human B-cell lymphotrophic virus, that is also having latency in the lymphoid tissue and help in the proliferation of lymphocytes. We have HH7, which follows the same rule. It can attack the lymphoid tissue for its latency and can cause proliferation in the lymphocytes. HHV8 is known to cause tumors in the blood vessels. Tumors in blood vessels. What are the extra data to be remembered about HHV6? This virus as such is known to be called as sixth disease. Why? Because on the 6th day of rash, you will be having fever. You will be having sixth disease, also referred to as exanthema subitum, also referred to as roseola infantum. So you understand that mostly it attacks the infants and there are erythematous skin rashes happening. If you do not actually give importance to this particular virus, in a child it can also lead to reactive febrile seizures. The same way Shigella flexneri might cause. The mechanism will be similar. Okay, what are the other questions that you can raise from the human simplex viruses? First, out of these HHV1 and 2, that is HSV1 and 2 only shows cross reactivity. It means if I have antibody towards HHV1, it can give mild protection against HHV2 and vice versa. But if you are willing to look at the differences between them, you look for restriction endonuclease analysis and DNA sequencing to find out the importance of these two organisms and look at them as separate organisms. What is the beauty of HHV6? I told you, exanthum subitum is also known for causing focal encephalitis, while HSV2 and HSV1 are very common causes of sporadic encephalitis. And when HSV1 attacks you multiple times, if it causes recurrent meningitis, it also called as Mollaret's meningitis. And HSV1 attacks the temporal lobe of the brain. Okay, this is how you look at herpes simplex virus on electron micrograph. What you see here is actually the inner and outer nucleocapsid of this organism. Now the long arrow here is pointing towards the nucleocapsid of the virion, and there is a dark area between that of the inner nucleocapsid and the outer envelope. This area is referred to as the tegument of the particular virus. This has been done when you have to go for a virion. Totally you have 1, 2 and 3 virions here. Remember, you will be having the envelope present on the outermost area. You have the inner nucleocapsid present in this area. Between the outer and the inner, you have a tegument area that is unique for the herpes simplex virus 1. Now this is seen as a Zaang smear. When you look at Zaang smear, they are seen as multinucleated giant cells. What do you mean? You have multiple nucleus present in this giant cell, which are T lymphocytes and granulomatous cells that are coming together. They have approximately 8 nuclei. This has been asked as MCQ in JIPMER exams. So in a multinucleated giant cells that is seen in a Zaang smear for HSV1 or 2, you can have approximately 8 nuclei. And this is the vaginal picture that is shown as a genitalia herpes. Remember, HSV2 is the most common virus affecting genitalia below the belt. HSV1 is the virus that attacks above the belt in 70% of cases. HSV1 and HSV2 can share similar kind of clinical features, but HSV1 mostly attacks your brain, HSV2 mostly attacks the genitalia. Okay, now comes the differences between that of HSV1 and 2. If you are looking at the latency period of HSV1 and HSV2, HSV1 shows latency in trigeminal ganglia, while HSV2 is showing it lower somewhere in the sacral ganglia. Also, if you are looking at HSV1 lesion, they are happening in head, neck and face, while HSV2 attacks genitalia. The primary infections of HSV1 will be like gingivostomatitis, pharyngitis, keratitis, conjunctivitis, etc. As I told you about the head, neck and face. While you will be having HSV2 causing neonatal infections if the mother is suffering from genitalia infections and the child is acquiring it directly. Okay, what is the mechanism of acquiring HSV1 then? It can be by direct droplet contact. Either it can be skin-to-skin contact or aerosolization. HSV2 is purely sexual. That marks the glorious difference between that of HSV1 and HSV2. Remember this for the rest of your life. You will be having a droplet infection for HSV1, while HSV2 comes as a sexual spread. Also remember, they can have no recurrent infections. This HSV2 has very minimal recurrence. Very minimal recurrence. And HSV1 will be showing a lot of recurrence by having herpes encephalitis or meningitis or eczematicum herpes eczematicum or eczema herpeticum. Both would mean the same. All these recurrences are possible in case of HSV1. They are not possible in case of HSV2. Also remember, HSV1 can attack children, while HSV2 attacks young adults who are sexually active. What is the importance of knowing these differences? By looking at the case history, if you look at any of these properties, you can zero in on HSV1. If you look at any of these properties, you can zero in on HSV2. There is no guarantee you'll remember every single line in this. But if you can remember one or two lines in this, which are drastically the opposite of each other, you will be able to answer, and you should be able to answer them better. So how do you treat them? You can go for acyclovir and simple antiviral agents. While HSV1 can respond to antiviral agents, HSV2 is generally resistant to the antiviral agents. Remember, recurrences are very common in HSV1 compared to that of HSV2. Okay, which kind of people are generally attacked by these kind of viruses? Obviously, it's not a virus who's going to attack animals. It attacks only human beings, and you'll also be having people among HSV2 acting as asymptomatic carriers. Now, to answer these questions, you should know certain features of the clinical features of the organism. What are the general clinical features? I told you, right? HSV1 is the most common cause of sporadic encephalitis, mainly attacking temporal lobe. The recurrent attack is called as Muller's meningitis. While HSV1 is also capable of causing follicular conjunctivitis, meningoencephalitis, and chorioretinitis, genitalia herpes is mostly caused by HSV2. The specific cutaneous features are: you will be having blisters of herpes. Also, you'll be having whitlow because of herpes, where there is infection of the pulp space. Usually, healthcare workers are the ones who will be suffering from it. Then you have mat herpes. What is that? It attacks the place where the wrestlers will be floating on the ground. Imagine a wrestler fighting in the ground. Every single place he falls on the ground, and the part of his body that is touching the ground will be under attack by this area. So they are also referred to as wrestler's infection. The old name for that would be herpes or herpes gladiatorum, attacking generally the thorax, ear, face, hands, etc. You also have herpeticum eczema. I just now told you, eczema based herpeticum can actually see general eruptions happening in children. Children are the people who generally are very difficult to control themselves from itching and scratching. So they will be having a lot of eczematous changes in the skin. This will also be referred to as Kaposi's varicelliform. Kaposi's varicelliform eruption. Okay. Now I told you already what are the different kinds of investigations you'll run. You can go for Zank's smear, where you're looking at multinucleated giant cells with ground glass appearance, and you can also look for intracellular or intranuclear inclusion bodies. The intranuclear inclusion bodies are referred to as Zank cells, also referred to as Lipskutz bodies. You can go for as regular DNA PCR. You can also go for CSF analysis when the meningoencephalitis is more severe in the meningitis state. Now, try to answer a few questions in this. Herpes simplex virus is a double-stranded DNA. Encephalitis is caused by HSV1. All the following are true about herpes group viruses except they're ether sensitive, they may cause malignancy, HSV2 involves willow diagram, Burkitt's lymphoma involves T cell, Burkitt's lymphoma involves B cell, so all are true except this one. Herpes group is actually a latent virus group, right? So the more persistence of an organism and locality, it can induce metaplasia, neoplasia, and malignancy. They are also responding to ether. Now this is the picture for temporal lobe encephalitis. This is a very clear marker to say it can be HSV1, which is not a useful test for diagnosis of herpes infection. You can run DNA analysis, you can go for serology, you can even culture the organism in the tissues. Microscopy is what we saw in case of Zank's smear. It tells me all of them are useful, so none of them is the answer. Herpes virus causes syncytial formation along with that of enterovirus and in case of Herpes virus causes syncytium formation. I told you about the different kind of cytopathological events. Enterovirus causes total sheet degeneration. Remember, pox viruses can cause pox lesions. This is the picture of chicken pox. You have most of them happening at the central truncal area and minimally towards the peripheral areas. That is the organism varicella zoster virus. Herpes zoster is caused by varicella virus. What is varicella zoster virus? It is a combination of two names. Like for example, I say Hero Honda. Benzes, that is Mercedes. Cut. We'll restart from here. What you're seeing here right now is chickenpox in front of you. Look at this. Chickenpox is generally caused by varicella zoster virus. And varicella zoster virus is a combination of two names, varicella and zoster. Varicella is known for causing chickenpox. Varicella is known for causing chicken pox, while zoster is the one that is known for causing zoster lesions, which is the reactivation symptoms. Varicella zoster is like calling something like Mercedes-Benz, Hero, Honda. It's a conglomeration of two major industries to come together to give a single product. The first primary infection caused by this virus is referred to as the chickenpox. When it goes for reactivation, comes back again, that is called as zoster lesion. Now, what are the things I want you to know? As always, humans are the only reservoir. No animals suffer from varicella zoster virus infection. You have this chickenpox attacking children mildly, but adults in a very severe fashion. So generally, it's a thought of consensus that you have to get varicella zoster virus in your childhood so that you can have lifelong immunity. The immune response given to the virus will stay with you because of memory for a very long time. 18 to 90% of people will not get a second time chickenpox. There is a possibility of having second time chickenpox also, but more than having a chickenpox, many of them will be having zoster lesions coming up. Okay, now if at all chickenpox attacks a human being, from that human being going to the next human being is very high. So secondary attack rate is very high, which is almost touching 90 to 100%. And this speaks about the contagious nature of the organism. It is highly contagious. Now, what is the incubation period for this? Approximately 3 weeks. It can even be 1 to 2 months. The patient will not have any signs and symptoms of having chickenpox. Suddenly, one fine day, he'll be having fever and he feels a lot of fatigue in himself. Slowly, he'll have itchy sensation. That itch and ick sensation will start becoming more painful. Then he realizes eruptions are happening everywhere. Most of the eruptions are the truncal and minimally he'll be having the periphery also. Here, the chickenpox rash is unique because there is rapid evolution of the rashes. You will not be able to know different stages. But different stages are definitely unique in case of varicella zoster virus because you'll have to begin with mapule, papule, where there is a small bump happening. Then you'll be having fluids filling the local area, clear serological fluid. If it becomes pus, it becomes pustule. So these stages can easily be covered in a very short duration, and the distribution is always centripetal. That is, they'll be present mostly on the trunk, very sparsely on the peripheral areas. Also remember, these are very superficial skin lesions looking like dewdrops. Such a kind of activity or such a kind of lesion can also be found in molluscum contagiosum. Remember, these vesicles have an erythematous base. That is what we saw here in this picture. Every time you look at the lesion, surrounding that you will be having an erythematous base which is red in color for the vesicular lesion that is happening. Also remember, when they happen, they always occur in the form of, the evolution happens in the form of crops of lesions. And these lesions can have different age groups. All the lesions will not be at the same stage. Multi-staged lesions can be seen at the same time. This is referred to as the pleomorphism of lesions or lesion pleomorpha. All lesions of different stages can be seen. Okay. Now, when can the crusting happens? From the time of eruption to the crusting, it takes maximum of 2 to 3 days. Once crusting happens, that lesion alone is non-infectious. And when will you call the patient as becoming non-infectious? When the last eruption has happened and the last crusting is done. When the last crusting has ever happened, then the patient is not contagious at all. He is safe to move among the public. Now remember, 1 week before the eruption and 2 weeks after the eruption is supposed to be the contagious period for the patient who is suffering from that of lesions. Okay, what is the most common complication chickenpox people suffer from? Since you have viral infection causing lesions everywhere, these lesions on minimal scratching can actually lead to secondary bacterial infection, secondary skin infections which are bacterial in nature. Also remember, this varicella can lead to varicella pneumonia if at all these children are actually infants or immunocompromised adults. Immunocompromised adults. You also have Ray's syndrome happening in children if at all NSAIDs have been used during the period of chickenpox. What is the treatment of choice for chickenpox? You can put the patient on acyclovir 800 milligrams a day. You can also go for ganciclovir or valacyclovir. All these are capable of decreasing the chances of latency, and also they attenuate the frequency of eruptions. They make healing happen faster. Okay, now think about the varicella getting from a pregnant female into a child. You have something called as maternal varicella. That is, the mother is suffering from varicella zoster virus infection for the first time. Now you can have two types of responses to the maternal varicella. If it is happening in the early stage of pregnancy, or it is happening during the late stage of pregnancy. In the early stage of pregnancy, you will be having fetal varicella syndrome. But if the mother is about to deliver, you call it as congenital varicella syndrome. Okay, what are the different kinds of features? If the child has been infected earlier, or the mother has been infected earlier, because of which there is an increased exposure for the fetus to the virus, the child will have limb going into hypoplasia. This is an example of a teratogenic change that can happen. Also, you can look for chorioretinitis. As you go nearer, it can also cause neonatal cataracts. And the brain size is smaller, which leads to microcephaly. Also remember, it can cause atrophy of the cortex. And when the child is born, it can show seizures. When all these things are happening, mental retardation is not very far away. Above all these things, you can also have skin lesions in the fetus, which are cicatrizing in nature. This can also affect the kidney of the fetus, which can lead to neonatal or in utero hydronephrosis. Hydronephrosis. All these are features of fetal varicella syndrome. Why? Because the chances of exposure of the fetus to the particular virus has been prolonged. Why? Because the mother acquired this infection very early in the pregnancy. If the mother is about to deliver, that is called as late stage of pregnancy, then the chances of risk to the fetus is slightly lesser, but still, nevertheless, the fetus can be affected. What happens here? Now you divide this period into two types. When the mother develops rash within 1 week of about to be giving delivery, that is within 7 days before delivery, if the mother is developing rashes, or you can also divide them into continue, or if the duration is more than 1 week before the delivery. Look at the beauty here. If the mother has received the rash, that is within 1 week of giving a delivery. For example, I say if it is November 4th is the delivery date. If the child is being given birth on November 4th, but the mother got the infection by October 29th, it is just 1 week within the time of delivery, right? So you have only the antigens, no time for antibodies to develop. So mother is not able to produce antibodies to fight the antigen. So the antigen is free enough to go back and attack the child. But if at all it is happening for more than 1 week before the delivery, the antigen is also there. While the mother is having enough amount of chances to produce antibody, the mother's antibodies and the mother's antigens both can reach the fetus. So you tell me which is actually safer for the fetus, whether only the antigen reaching the fetus or both the antigen and the antibody reaching the fetus. Obviously, antigen plus antibody reaching the fetus is better. So that would mean to say that fetus has no clinical features. While if it is happening within 1 week of having delivery, the virus alone reaches the fetus, because of which the baby should be protected. How do you protect? Because the virus antigen has already reached. Now you can't expect an active immunity to jump into equation. So you have to protect using passive immunity only. And what is passive immunity? Giving a vaccination or giving antibodies. You have to go for anti-varicella zoster virus antibody serum to the infant. The baby should be given that along with acyclovir low dose. This can help to save the baby suffering from that of future constraints. Again, as you saw in case of herpes simplex virus, if you want to make a diagnosis, you just have to go for Zank smear, and you can also go for DNA PCR. Remember, PCR can be the ultimate investigation of choice if you don't know anything about a particular virus. If it's a DNA virus, go for DNA PCR. If it's an RNA virus, go for RNA PCR. If PCR is not enough, then think about looking for the load of the virus. Look for DNA viral load. Look for RNA viral load. The answer will be almost correct. Whatever we spoke is about how a mother can give the infection to the child, and also how an adult or a young person can actually acquire this infection at the first level. What about zoster? If you want to know about reactivation, then you call them as singles or zoster. This should happen when a person has already been infected. Previous infection is a must for the reactivation to happen. What are the different types of or varieties of zoster that you come across? You have sign herpetica. So if it is sign herpetica, you look for pain along single dermatome. What is so unique about it? There are no rashes, but you have positive evidence in the serum that there is zoster running up. What is Ramsay-Hunt syndrome? This tells us that the eruptions have happened on the tympanic membrane all through the external auditory canal. And why did this happen here? Because the organism is actually running again on the facial nerves. So facial nerve pain is unique for Ramsay-Hunt syndrome. Next, look for zoster ophthalmicus. That tells you there is reactivation of the same virus. If it is happening in the facial nerve, you call it as Ramsay-Hunt syndrome. If it is happening on the ophthalmic branch of trigeminal nerve, ophthalmic branch of trigeminal nerve, you will call it as herpes zoster ophthalmicus. Which kind of patients are more prone to go for these kind of zosters? People who are suffering from Hodgkin's lymphoma, non-Hodgkin's lymphoma, even people who are suffering from AIDS or any other kind of cell immunity suppression, all these people are capable of going for reactivation, and you always have the virus being latent in the sensory ganglion. Also remember, the most common complication would always be post-herpetic neuralgia, where you can have pain along with that of the rashes. So that brings us to the treatment protocol. If at all you want to look for the treatment of varicella, remember, if the child is immunocompetent, for an immunocompetent child, treatment is not necessary. But if it is adult, then it's good to give him treatment, because I told you in adults the disease becomes more severe because of reactivation. So you can actually give the patient acyclovir, but remember, if the patient as an adult is immunosuppressed, you are giving this acyclovir to prevent complications. You can't attenuate the lesions. This is completely opposite picture when you have in case of giving this drug when the patient is immunocompetent. In immunocompetent people, it not only prevents the reactivation, it also will be able to help block the latency and also decreases the duration of the lesions, not in case of immunosuppression. Now, if this is chemoprophylaxis and chemo treatment, there is a concept of immunoprophylaxis in case of varicella zoster virus. There is a live virus which is attenuated called as OCA vaccine. And this OCA vaccine is contraindicated in AIDS patients, not just HIV. In AIDS patients, you can actually contradict it. Why this OCA vaccine is dangerous? Because it is attenuated virus, right? So in case of people who do not actually have enough amount of CMI to deal with the organism of the virus can actually beat up the CMI and can progress forward. It can start its own latency and its own complications. Okay, what is that you have good about this particular vaccine? It can produce 90% seroconversion at the minimal. It can go up to 95% seroconversion at the first dose itself. And this particular vaccine efficiency can be noted for approximately 10 years. But the vaccine is slightly expensive. Remember, you can give it for children who are more than 12 years of age to begin with. And you will be having children who are the people who are going for 95% seroconversion. If you're going to give it for adults, then you can expect 75 to 90% seroconversion adults after 2 doses. And if this is vaccination who is called as active immunization, how will you work out the passive immunization? Passive immunization is going to give VZI globulin. Varicella zoster immunoglobulin is useless if given after the onset of clinical features and symptoms, but can be effective on first exposure. Just exposure has happened and you're trying to protect the patient, then it can be useful very efficiently. And what is the maximum duration you can give it? That is less than 10 days of exposure, while the best work happens within less than 96 hours of exposure. Okay, now let's try to answer a few MCQs from this particular topic. Herpes zoster is caused by varicella. Most common extra skin manifestation of varicella is involvement of CNS, but the most dangerous is pneumonia, which is involvement of lung. Which virus reactivates and involves the eye? Herpes zoster ophthalmicus. Remember, herpes zoster is not just a virus. We have to use the word varicella zoster, and the disease is herpes zoster. Now this is what you see as the organism attacking a single skin lesion. Varicella zoster remains latent in trigeminal ganglion when it tries to attack and cause varicella zoster ophthalmicus. Zoster recurrence occurs after infection with that of varicella infection. This is called as a dermatomal injury. A single dermatome is actually suffering from rashes and that of pain. Post-herpetic neuralgia can be seen. Okay, infectivity of chickenpox will last 6 days after the onset of rash, and you can go for testing of chickenpox using PCR, ELISA, FAMA, fluorescent mediated antibody detection, and you can also go for fast ELISA. And remember, it can always cause pneumonitis if the patient is immunosuppressed, and it can be causing severe infection in the newborn child who is infected with the mother who is suffering from the late pregnancy attack. Okay, now let's go for the next organism called as Epstein-Barr virus.